Final Silence by Ju-Won Kim, MD, PhD. She had already been through every available line of chemotherapy. We had tried everything. When the scans returned showing aggressive progression of metastatic bile duct cancer despite treatment, there was nothing more we could do. It was time to talk about hospice care. This happened early in my career, when I was still learning not just the science of medicine, but the emotional terrain that comes with being entrusted with someone's final days. In South Korea, where I practice, families are tightly knit but emotionally restrained. Duty often comes before open affection, and caregiving responsibilities pass silently from one generation to the next. I was new to these kinds of decisions, unsteady in my ability to hold grief without flinching, especially within these cultural frames. She was always alone. No husband, no siblings, no visible network of support. She had once told me she was divorced and had a daughter, but I had never seen the daughter accompany her. She came to every appointment on her own, asked all the right questions, and even smiled sometimes as if to reassure me that she was okay. But she was not. Her 40-something body was failing, and time was running out. When we realized she would soon need to transition to hospice, I told her gently that it might be a good time to have her family come. She nodded, but didn't answer right away. Later that day, her mother arrived, an older woman, stooped and weary, whose anxious glances and hesitant questions made it clear she had not been told the full extent of her daughter's illness. I remember her clutching her handbag tightly, her face blank with confusion, until I sat down with her and explained the situation. She broke down. Through her sobs, she told me she had been caring for her own elderly mother, who had dementia, and had not realized how serious things had gotten for her daughter. In a society where elder care is often handled within the home by women, her burden had been invisible, even to herself. She thought her daughter had more time. The next day, the daughter came, the patient's daughter, young, smartly dressed, with a kind but tired face. She had been working in another city, she said, and hadn't known her mother was at the end of her life. Like many young adults in Korea, she had left her hometown for economic opportunity, a move often accompanied by a silent drift from aging parents who rarely ask for help. I explained things to her as gently as I could. She listened quietly. She didn't cry, but her silence was heavy, like a room with all the windows shut tight. She left with a promise to come back soon. We planned the transfer to a hospice facility. Everything was ready, paperwork completed, and pain managed. On the morning of the transfer, I received an unexpected call from a neurosurgeon in our hospital. He told me that my patient's daughter was in his intensive care unit, brain dead. She had attempted suicide the night after visiting her mother and was found unconscious. The neurosurgeon had reached out to me because the daughter had no immediate guardian, and they were preparing to approach the family about organ donation. He had looked into the patient's records and saw that I was listed as the mother's primary oncologist. I stood frozen, the phone still pressed to my ear, unable to process what I had just heard. The hospice team was waiting. The ambulance was scheduled to arrive within the hour. We still needed a legal form signed for the patient's daughter, a life-sustaining treatment decision form, similar to a physician orders for life-sustaining treatment used in Korea to document a patient's wishes about life-sustaining treatment, which required 2 immediate family members' consent. Yet one of those family members was about to leave for hospice care, just a few floors above us. I did not know what to do. How could I tell my patient that her only daughter, her last remaining support, had tried to end her life and now lay without brain activity in the same hospital? I paced, I debated, I wrote half-finished sentences in the medical record. In the end, I said nothing. The hospice ambulance came. We loaded her carefully. I stood there as they wheeled her away, her face calm, eyes closed. She never knew. To this day, I carry the guilt of that silence. I think about it more often than I admit. Did she sense something was wrong that morning? Did she wonder why her daughter was not there? Did she leave this world waiting for a voice that never came? I told myself I was protecting her. I believed that to burden her in her final hours with such unthinkable news would be cruel. But a deeper truth is that I was protecting myself. I did not know how to say it. I did not know how to bear the weight of her devastation on top of my own shock and helplessness. So I avoided it. I let her go without telling her the truth. That decision has never stopped echoing inside me. By not telling her, I might have also denied her the chance to mourn her daughter, or at least to understand her absence. Perhaps she wondered why her daughter did not return. Perhaps she felt abandoned. That unspoken doubt still haunts me. There were 4 women across 4 generations. An elderly great-grandmother who needed care, a mother who did not know her daughter was dying, a daughter who died before she could say goodbye, and a patient who did not know that she was not the first to leave. When I think of her, I do not think only of death. I think of the weight of unspoken things, the daughter who did not know or could not face the truth of her mother's illness, the mother who had not realized the depth of her daughter's suffering, the patient who carried her pain so quietly that no one, not even those who loved her, knew how near the end she truly was. In medicine, we often focus on the patient in front of us, but illness ripples outward. It touches families, friends, and colleagues. Sometimes the greatest pain is not the physical burden of disease, but the emotional cost paid by those around it. I do not know what would have happened if I had pushed earlier for the daughter to come. I do not know if the outcome would have changed, but I do know that silence is not neutral. Silence is a weight. In this family, it became unbearable. If this happened to me now, years later, would I be braver? Would I find the words to tell her? Would I choose differently? I still do not know. Since then, I have tried to be more courageous. I try to call earlier. I try to ask better questions. I try to look beyond the laboratory results and scan images and into the silence between words. Sometimes we heal not by curing, but by witnessing, by being present in someone's final chapter, not as a rescuer, but as a listener. Sometimes we carry stories not because they are exceptional, but because they remind us of what it means to be human.
Welcome back to JCO's Cancer Stories, the Art of Oncology. This ASCO podcast features intimate narratives and perspectives from authors exploring their experiences in oncology. I'm your host, Mikkael Sekeres. I'm Professor of Medicine and Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. We are so thrilled to have joining us today Dr. Joo-Won Kim. She is Assistant Professor at Korea University College of Medicine, and she's here to discuss her Journal of Clinical Oncology article, Final Silence. Joo-Won, thank you for contributing to Journal of Clinical Oncology and for joining us today to discuss your article.
Hello, Mikkael. It's really nice to be here. Thanks so much for inviting me.
It's so nice to have you here today also. Thank you for also taking time so late in the evening because our time difference is so huge.
Yeah, it's not that late. It's 9 o'clock in Seoul, 9 p.m.
I wonder if I could start by asking you if you can tell us about yourself. Could you walk us through your career so far?
Yes, I'm Joo-Won Kim from Korea University in Seoul. I was born and also raised here and never really left from Seoul. I did my residency in internal medicine and fellowship in oncology at the same hospital, and now I'm an assistant professor in there. So you could say I've spent my whole life on the same campus, just moving from one side of the hallway to another.
It's a beautiful way of describing it. Is that common in Korea for somebody to remain at the same institution for training and then to continue through your career?
It used to be common about a decade ago, but nowadays it is not that common. Most of my colleagues from another campus or another hospital.
Well, I'm so curious, what is a typical week like for you? How many days do you spend seeing patients and how much time do you spend doing research or writing or have other responsibilities?
Usually I spend 4 times for my outpatient clinic But in Korea, there are so many cancer patients and so little number of medical oncologists. I usually treat so many patients in one clinic, like maybe 20 to 30 in one time.
Wow.
Yeah, that's a burden. Most of the time I spend treating my patients, and the rest of them I used to spend for my research with my lab students and maybe with my colleagues. And I have to write something like documents or some kind of medical articles. That is about 10 or 20% of my working time, I think.
Okay. Okay. That makes sense. So, and do you specialize within oncology or do you see any person who has cancer?
I'm a medical oncologist and I used to treat breast cancer or biliary pancreatic cancer or some kind of liver cancer or rare cancer, maybe also.
Okay. Okay. It's such a long trip. Are you able to make it to the ASCO annual meeting in Chicago?
Actually, I've been in Chicago for ASCO meeting just one time in this year. I gave birth of my son at March, and I was in the long vacation for my birth. In the last part of my birth vacation, I went to Chicago to participate ASCO. It was a really good time.
Oh, fantastic. That's great. How about your own story as a writer? How long have you been writing narrative pieces and when did you start?
Actually, I've always thought of myself more as a reader than a writer. Reading was my comfort zone from the child. Then I started a small book club with friends about 10 years ago, and we began writing short reflections after each meeting. That's how writing slowly became part of my routine. When reading feels heavy, I write. When writing feels tiring, I read. It's a rhythm that keeps me balanced. At first, it was only academic writing, like medical articles. But a few years ago, I challenged myself to post one short reflection a month on my Instagram, usually a quote from a book and a few sentences on why it mattered to me. It was my life about writing.
That is really remarkable. So, did you take any formal writing classes at university?
Not really, it was just a hobby for my own.
It always impresses me when people come into writing organically like this, where they just discover it and start and don't have formal teaching because your writing is very, very good.
Oh, thank you.
And how do you find the time to read and write when you have a busy career, academic career, and you have a child?
It was my old routine that I used to read it before going to bed from my bedside with a small light. I used to read some novels and get to sleep easily. But after I started to work as a medical oncologist, it was very busy job, as you know. I used to sleep more and not to have time for reading. I try to read more when I get some free time.
I love how you talk about alternating reading and writing and how when one gets too heavy, you go to the other and then you switch back. One of the most common pieces of advice I've heard from writers is to read more.
Yeah,
You can see how other people put thoughts together and the cadence of their writing. And also, it inspires your mind to develop new ideas for writing.
actually, the new idea also comes from the book, I think. When I came into a new book and the idea bangs up with me, so I started to write, and that's an easy way to have some idea about writing.
I'm always impressed by people who are facile with languages and bilingual or trilingual. I think I'm unfortunately a hopeless monoglot.
Maybe
um,
you can try Korean.
I think I'd be embarrassed to even attempt it. When you read, do you read in Korean or do you read in English or other languages?
Definitely in Korean.
Okay, okay.
Yeah.
And when do you find the space to write? Do you need to be alone at home in a special room or at a special desk, or do you write at work, or do you just find any time to write?
I usually don't have much time for my own because I have my baby now and some family gathers frequently. So I always write every free time I trying to any short free time in my work, maybe.
Uh-huh. If you feel comfortable doing so, this is a very heavy piece. And a lot of us have dealt with deaths of our own patients, of course. We see this unfortunately commonly in oncology, but many of us, myself included, have also dealt with patients or their family members who've committed suicide. Can you tell us what prompted you to write this piece?
As an oncologist treating biliary and pancreatic cancers, I've witnessed many deaths, as you know. Most fade with time because I treated so many patients, but just one family stayed with me, I think. It was early in my career, just months after I started this specialty. And even 5 years later, I still think about them, the family I wrote in the final silence. The story eventually became the piece I wrote.
And what is it about them that caused you to think about them so much even years later?
I'm not sure. That's the only experience I came into someone's suicide so closely in my life, I think. And also, it happened in my very early career. That's the impact.
It is amazing how certain patients stick with us even years or decades later, particularly when they're tied to an emotional response to illness. And that can be our patient's emotional response or our own. Can you talk some about Korean culture and how cancer is viewed? Is it discussed openly?
In Korea, death is still a quiet topic. Cancer equals death in many people's minds, and death equals grief. Even today, some families ask doctors not to tell their patients about the diagnosis. But Korea is aging so fast, so I see more older patients now. But culturally, we are still learning how to talk about dying openly. That's the big problem as a medical oncologist, especially treating biliary and pancreatic cancers.
Uh-huh. I can just imagine. When you first meet a patient and their family is in the room, do you tell them that they have cancer, or do you need to check in with the family and with the patient how much they know about their diagnosis first?
Actually, I usually try to tell them there is a cancer which can be never be treated perfectly because I used to treat patients with stage 4, which is incurable, but I'm not sure is it okay to tell them that your life is about 3 months or 6 months or 1 year. It is not that okay for the Korean patients, especially the first time when they meet me in the clinic. I try to tell them about the truth just a few times later.
I think that's common. I think we do that in the United States also. We may not mention a number to patients during that very first meeting because when you're talking to somebody, once you mention that number, often people will shut down. They won't hear anything else that you say. And you need to build up a relationship and some trust with somebody and also get the sense how much they want to know about their cancer and their prognosis before entering that conversation. I've certainly had instances when I'm in a room with a patient and that patient's spouse or children, and someone else in the room will say, "How long does dad have to live?" And I've turned to my patient, dad, and said, "Is this a number that you want to know?" And the patient has said, "No, I don't."
Yeah,
So,
that
some
happens.
so sometimes we have to be careful and check in and remind ourselves in the high emotions around a cancer diagnosis that our first responsibility is always to our patient and what they want to know about their diagnosis and their prognosis.
Do you have any opposite cases that patients really wants to know the numbers?
Yeah, I do. And, you can almost predict who that's going to be depending on what they did during their lives.
Yes.
So I have patients who are engineers or who are who have a math-based career, like they're accountants, and they'll come in and they write every number down and they want to know the number about their prognosis. And I have other patients who are English professors and they want descriptively to know what the prognosis is, but maybe don't want a number. So
I think most of the Korean wants the number, the specific number. Yeah.
I'm curious, is cancer in a father or a son dealt with differently than cancer in a mother or a daughter?
I don't think there's much difference between sons and daughters, or maybe moms and dad, because every child is very precious in Korea now. But between husband and wives, I think the dynamic stands out. The people often say when a husband gets cancer, the wife becomes his main caregiver. But when the wife gets cancer, sometimes the husband disappears. I've heard that from my colleagues, though not often in my own clinic. What I do see is many middle-aged women who has diagnosed breast cancer, women coming to treatment alone, strong and very independent.
Huh, interesting. So I was going to follow up by asking if you've seen that in your own clinic. Have you seen, is it more likely that your female patients who have a cancer diagnosis come to clinic alone, but the male patients come with their spouse and with family support?
Yeah, it is not just because they are sex, but the most of the breast cancer who is female is in very good condition, but biliary pancreatic cancer male patients has very poor condition. So
Ah,
maybe I think that's the problem.
interesting. The part of your essay in which you describe the attempted suicide of your patient's daughter is absolutely chilling. How did that affect you? Have you ever had a patient attempt suicide before?
Yes, the event I wrote in my essay was extremely shocking for me, but it's the only experience I have. It wasn't not my patient, but I've heard a few cases where someone in the hospital tried to take their own life. I haven't had that happen directly, but I've seen patients fall into deep depression or break down in tears. In those moments, I always suggest psychiatry nowadays that used to be taboo in here, but the stigma is fading and many patients actually feel better afterwards. I also check in with close family members because their mental state affects the patients too. It's something I hope never to experience again.
It's so unsettling when that happens. And as I mentioned, I've had a patient who took his own life, and you go back and back and back to it to wonder if there's something you could have done to intervene quicker or to get that psychosocial support in place to help that patient so that you avoid it in the future. And, you protect your patients and yourself.
Yeah, I try to.
Speaking of protecting, you write, and I'm going to quote you to you. I told myself I was protecting her, that to burden her in her final hours with such unthinkable news would be cruel. But a deeper truth is that I was protecting myself. I didn't know how to say it. I didn't know how to bear the weight of her devastation on top of my own shock and helplessness, so I avoided it. Do we owe it to ourselves sometimes to protect ourselves from the pain we sometimes impart to our patients?
That reflection came from realizing how doctors sometimes say we are protecting patients from pain, but really we're protecting ourselves, I think. It's human. We can't hold every piece of suffering we see. Setting emotional boundaries isn't weakness, it's survival. What matters is recognizing when it's self protection and being honest about it later.
Well, I think something that really helps with that is being able to talk to our colleagues about times when this happens and recognize we're in a shared experience and that we have the support of our colleagues and they recognize how hard it is to be the bearer of bad news to other people and to bring pain to them sometimes.
That really works.
Dr. Juwon Kim, it has been such a pleasure having you on this show. Dr. Kim has written just a fabulous essay called Final Silence for JCO Art of Oncology. Thank you so much for sharing your article with us and for joining us today.
Yeah, thank you so much for the conversation. It was a pleasure talking with you.
If you've enjoyed this episode, consider sharing it with a friend or colleague, or leave us a review. Your feedback and support helps us continue to have these important conversations. If you're looking for more episodes and context, follow our show on Apple, Spotify, or wherever you listen and explore more from ASCO at asco.org/podcasts. Until next time, this has been Mikkael Sekeres for Cancer Stories.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.